Good afternoon and welcome to the Revenue Cycle Management and Back Office Supports for the New Healthcare Environment webinar. I'm Michael Flora with MTM Services. It's my pleasure to be with you this afternoon as we really look at how the environment is changing in community behavioral health care. And we must be able to look at our revenue cycle and really see how our back office supports are helping us or hurting us along the way. So good afternoon, everybody. Welcome. A little bit about MTM Services. These are a few of our publications. You can go on the National Council website and review those. This is the MTM Services team with David Lloyd, our founder, and the rest of the MTM faculty. Our most recent publication is Operationalizing Health Reform, How to Get and Keep the Best Employees, our Health Reform Implementer newsletter, which comes out bi-monthly, as well as a little bit about MTM Services, is that we're a national consulting firm that has worked with over 700 providers, mental health, substance use, PD, and residential in 45 states and 2 foreign countries. MTM Services has access redesign experience, including individual clients. We're looking at 5 National Council-funded access redesign grants with 200 organizations across 25 states. 6 statewide efforts with 140 organizations and over 1,500 individual flowcharts and over $16 million in annualized savings for those 200 plus providers, and obviously a lot of happy staff and consumers. Today's webinar, we're going to focus primarily on organizational revenue cycle management needs and back office infrastructure to support pre-service, point of service, and post-service needs to enhance performance, reducing time between service delivery and payment, improving revenue percentages for providers, improving access to care through greater efficiencies, and revenue cycle management tips. What we're finding across the country, team, is the behavioral health competencies continues to shift and change, all centered around recovery and rehabilitation. So if we look at access to intake, time to treatment, governance leadership, outreach and marketing, management information systems, compliance, billing and financial management, and service scheduling are all new competencies or existing competencies that need to be enhanced in the new healthcare environment. The new healthcare reform leadership challenges that we're seeing is developing participating integrated care units to support the total wellness needs of the population. Moving more toward the population management models we're seeing in larger healthcare. Instead of seeing one client at a time, the model now levels care for the entire criteria, shifting from volume of services to value of services. As a revenue model, we're seeing some of those models pop up across the country. Operating in a shared risk savings funding model based on bundled payments or episode of care cycles. Identification of client-centered outcomes in an integrated healthcare model instead of fidelity process or measurement outcomes. We're also seeing cost finding for a process and treatment episode of care per CPT code used by population. And do we know our costs by CPT code or HCPCS code by provider type, whether it's APRN, MD, bachelor's level, master's level, licensed clinician? What does it cost us to provide that care? What is the cost of that level of care for those individuals served? And making the best business case for your agencies, managed care organizations, and accountable care organizations. What we're finding, the largest individual leadership challenge, is that we have to make some tough decisions in an era of change and stick with those decisions to face the challenge. It's what we call blinking. Have you ever made a decision, team, where we have opportunity to make a change? However, what we find is that, if you do that, John, what's going to happen is Sally's going to quit. And so one of the things we may want to look at is how do we help those folks? Other things we're seeing is a willingness for behavioral health care leaders to continually step across the threshold of risk to make bold and creative decisions about the delivery process and what tools are needed to support minimizing decision and making risks. Delivering value of care in an integrated environment to behavioral health care is very simple. We're seeing clinics all across the country really having an excellent opportunity to be helpful partners in the new integrated healthcare system if we can display the following specific values. Part of those are being accessible. How quickly can we get folks in for service? And promoting same-day access, centralized scheduling. Be efficient, provide high-quality services at the lowest possible cost. Be connected, have the ability to share core clinical information electronically across systems, not just internally. Can we connect with primary care? Can we connect with payers? Be accountable, produce measurement information about the clinical outcomes we've achieved, and be resilient. Have the ability or willingness to use alternative payment methods, be able to have that shared risk that we're seeing nationally. And how do we fit into larger healthcare? The Institute of Healthcare Improvement has looked at the triple aim. With hospitals moving towards value-based payment systems, there's more demand now than ever before for strategies that will help healthcare systems hone in on population health. The triple aim really focusing on population health, experience of care, and lower per capita costs. And we're seeing that in a lot of markets where ACEs, accountable care entities, or even ACOs are coming to the table, and many of them being larger healthcare systems primarily, and then subcapping or putting even providers such as ourselves at risk in capitation to help them bend the cost curve in getting the cost of Medicaid recipients down. Other healthcare reform or shared risk models that we're seeing from full risk capitation sub-cap rates per member per month, and maybe some of you have had that experience in your state, all the way down to fee for service. And again, moving away from that pay for value and moving away, or pay for volume, and moving towards pay for value. And so we're seeing more bundled payment rates, episode of care rates, and risk shared strategy, stratified case rates and shared risk, prospective payments. And we're seeing a lot of that even come out of the CCDAC model nationally, whether it's a per member per month or a per member per day cost, and global payments, all centered around shared risk, where payments based on a zero-based budgeting exercise that integrates complexity and severity of the population. So what does it cost us to provide care to a level of, let's say, a deeply ill individual? Let's say it's a level 5 where they're almost ACT. What does it cost us to provide that care? Other things we're seeing that's making the back office or revenue cycle more challenging is that as parity and national integrated health care provided under the Affordable Care Act continues to be implemented, again, those shared risk funding models are being introduced. Shift of payers such as Medicaid and Medicare and third-party insurance from paying from volume to value, and a large majority of community behavioral health care organizations are not having an ongoing awareness of their cost of services. Important definition of quality is that outcomes achieved to objectively demonstrate that the client is actually getting better, and combined with the service array, frequency, and duration provided, and the cost of the process of treatment linked to the outcomes achieved. The ability of staff to develop a dynamic tension between quality and cost, and the ability to know levels of net revenue received for services, not rates billed. So what is the claim denial or error rate last week, last month, last quarter for your organization? What is the level of overutilization of captured grant funding received that reduces the net revenue earned per service, let's say from $82 billed, but if I'm overproducing on that grant, then I've reduced that rate to $39.75 per hour per se. I was working with a team recently in upstate, and just in failed claims, they had $1.2 billion. And no one was following up on those claims. Why? Well, because the state was paying them $112 grand. But they still had to adjudicate the claims and justify the encounters. So they never really followed up on it. And in the new environment, that's not going to fly. We're going to have to be able to bill and get it out the door. The other thing we're seeing is even Medicare is starting to penalize providers for not meeting specific funding or outcome measures. So Medicare is penalizing 721 hospitals with high rates of potentially avoidable mistake that can harm patients, known as hospital-acquired conditions. So again, these penalties are a percentage off their actual payment. And so what's that going to look like for behavioral health care down the road? What's our outcome for ED visits for Medicare or Medicaid populations? Can we move individuals out of the emergency department to receive their primary care? Can we help them get out of the emergency room to receive their medication management or receive psychiatrists? The other thing we're seeing is states are shifting across the country from carve-out behavioral health fundings from 1115 general integrated waivers with Alabama, Arizona, Arkansas, California. You can see them. And over 40 states have modified their state Medicaid plans since 2010. Think about that. Think how Medicaid is evolving across our country from 1915 carve-out waivers to carve-in and 1115. The other thing we're seeing nationally is accountable care organizations and shared savings plans are being created by CMS with over 600 announced certifications for Medicare and Medicaid beneficiaries. applied under Section 2703 of the Affordable Care Act to develop integrated care health homes, Missouri, New York, Ohio, Connecticut. FQHCs have over 8,000 locations nationally, and they're still growing. Targeted to increase the number of persons served from 19.8 million in 2010 to 40 million by 2015. And they're the only part of healthcare that's getting more money, with $11 billion new dollars available under the Affordable Care Act. Just to kind of illustrate how things are changing, look at how the growth of ACO's Medicare and Medicaid shared savings nationally have grown since fourth quarter of 2010 to fourth quarter of 2013, where before we had 41 accountable care organizations in shared savings entities nationally. Now we're seeing over 606 affordable care organizations. Look at the number of covered lives and how that trend continues to go up, where over 20 million covered lives are being shared under the ACO model. Estimated number of total health-centered patients under healthcare reform, again, over 40 million. And so what's that value? How does that help us on community behavioral health care or substance abuse providers? Well, we have to look at the services provided. Timely access to clinical and medical services, our service array, duration, density of services, through level of care, benefit design, evidence-based practices, the actual cost of services, the outcomes achieved. How do we know that clients are actually getting better? What outcome measure are we using? Are we using the DLA-20? What other outcome measures are we showing that individuals are actually increasing in their overall functionality? And value is determined based on, can you achieve the same or better outcomes with a change of service delivery or a change in service process costs, which make the outcome under the new clinical care model a better value for the payer. Keyword there, payer. And so it all centers around the customer. And the back office component, the revenue cycle piece, we have many customers along that supply chain. We have the individual and family seeking care. We have the payer. We have the internal customer. We have the internal customer service at the back office, which in many cases is poorly run in a lot of the organizations we see, because it's very antiquated. We're not really up to speed on what we're doing. And if you really look at kind of behavioral health care centers of excellence, that things are moving along the pipeline, we're saying it's an organization or a program within an organization that is an integral part of the healthcare neighborhood, providing rapid access to specialty behavioral health services that include high volume, comprehensive whole person care that supports resiliency and recovery and results in excellent outcomes and high client satisfaction. With that, there are 5 key elements. Easy access, customer service built on a culture of staff and client engagement and wellness, comprehensive care, excellent outcomes, and excellent value. Are you sensing a trend yet? So let's talk about revenue cycle management. There has to be a greater understanding of cash flows and management of billing processes, because that's going to be what's needed in this healthcare environment. So the questions I ask you today, how long is your billing process? Are you billing weekly? Can you process third-party claims daily? What is your percent of denials? What is your performance standard on reconciliation of billing errors? For example, APT organizations shall have no more than the 95%, 5% error rate on denials. That 5% error rate must be re-adjudicated and reclaimed within 48 hours. What percentage of copays and self-pay amounts are you collecting daily? You establish a daily collection figure for your front desk. Right now we have, in our budgets, we have the line item as client fees. Let's say that's $200,000. And so what's going to happen there is, breaking that down by $260,000, I'm going to need to start collecting X number of dollars per day in order to meet that goal. And putting a key performance indicator or a non-clinical productivity expectation on your front desk that they're going to collect $1,000 today. And if they collect over $1,000, there'll be an incentive. Because what we know is that with the Affordable Care Act, that many consumers and families that they've received services a year and a half, 2 years ago, that were indigent, and they have fallen into your grant, aid, or other state funding. What we see in charity care before the Affordable Care Act has now been added that this year. Because many of these consumers, they're still at the poverty level with their income. They're just having a $7,000 deductible, which they will never meet. And so the challenge is they can't afford to pay you full fee at the front desk. So we're finding many organizations going into doing much a month, but then bill the client. But what's happening is that's turning into more and more bad debt. So here's a sample productivity KPI for front desk. 85% of all appointments that are canceled within 40 hours can be backfilled. Business and billing office, denial rate of insurance payments will be less than 1%. So again, putting those key performance indicators in much the same way that we've had productivity and performance measures for our clinical staff, now we're going to start developing these KPIs, performance measures for our non-billable staff. And so it really all breaks down to, again, that pre-service, which is admission, eligibility, pre-service audit, authorization, verification, and now I'm open to schedule. Then point of service, this is when I come in. Copay collection, I get my treatment. Post-session scheduling, post-service audit. And then post-service would be our billing, our denial management, our accounts receivable management, cash posting, and consumer follow-up. Each one of these areas would have their own separate key performance indicator. So where's revenue cycle impact? It impacts our reimbursement reductions, technology efficiencies. We're seeing that's a stumbling block for many organizations. Compliance program effectiveness. We're scheduling clients, providing care with clients that maybe don't have authorization service. Treatment plan isn't up to date. There's no verification of payer. The quality of care indicator, revenue cycle impacts that. The new and expanded payment methodologies that we talked about at the beginning of our webinar, and insurance expansion and availability. Are we on panels? Are we diversifying our payer mix that meets the needs of our organization? And so if you look at your communities that you serve, are we on the largest employer's insurance panel in your market? Are we providing that level of care? Other challenges that we see in revenue cycles, efficient and effective operations will help to minimize and impact healthcare reform, example, compliance, rates, outcomes-focused integration, and the new complicated Medicare and Medicaid rules. Processes, again, referral. Are we getting the right referral in the door? Do we have the right authorization process? Are we getting that authorization before they can commit even to an open access model? And to our scheduling, are we verifying payer? Think primary care. That my primary care physician doesn't let me see the doctor unless I pay my copay and hand over my insurance card. Then we're seeing challenges that impact revenue cycle with encountering documentation. This is the failed claims that we see. That the therapist may have done the note but didn't sign it. Charge capture. What's interesting, and I've been doing a lot of revenue cycle back office work nationally, and what we're seeing is that many organizations don't have a charge capture or charge master. Their billing processes are dependent, very heavily dependent on electronic medical records. There's a challenge with follow-up and cash posting to client accounts, including Medicaid and even grant funding. So the question is, who's your payers now? And what payers will you need in the future? What will the payer requirements be? Managed care, MCO, accountable care organization. What is the billing process that they're looking for? What's the timely filing of claims going to be looking like? Are your modifiers in place for ICD-10? What codes are you primarily using? What's your top 25 billing codes? What are the documentation standards, not like state but federal? And then think about what other issues might be impacting, whether it's staffing capacity, because one of the things we've seen is that we have, over the years, have, through attrition perhaps, is not beefed up our back office as we once had. In the good old days, we had a lot of staff, even though we only had one payer in the door. Now we have multiple payers, but we have fewer staff to actually fill that claim. So expect a significant increase in demand and referrals when you increase access to Medicare and even Medicaid members. We're seeing more and more Medicare individuals coming into play. There's 10,000 individuals turning 65 every day in this country. Medicare is going to be the new growth model for many organizations. Challenge is we may not have the appropriate providers on our staff to be able to do that. We're seeing higher deductible plans become more and more common, and providers must gather accurate demographic and payer information at the point of service in order to anticipate potential problem areas. So are we gathering that information? And that we'll talk about that in a minute of the pre-service audit. And this is an audit that happens 72 hours prior to the customer coming in the door. So some of the solutions to the challenges that we're seeing with revenue cycle is we have to analyze the staffing levels and capabilities now to determine their ability being passed not only increase referrals, but as it stands today. Organizations with numerous satellites may want to consider consolidating some of the billing functions to one centralized function, develop new policies and procedures, or currently review current policies and procedures, train staff on the process, training, and education of consumers will be critical at this point, because now I didn't have to pay for services prior to perhaps addressing the back office revenue cycle issue, but now you're going to ask me for my copay, you're going to ask me for my 20% Medicare deductible or copay insurance, and that's going to be a challenge for many providers. Providers should expect the authorizations will be shorter over time, and we're seeing that a lot, especially for high-end service like residential.
Hi there, this is Tabitha Jensen. Is anyone else on the line?
Yes, this is Lisa Carpenter.
Bradbury.
Yeah, this is Joe Asbridge.
And have you all lost our presenter?
Yes.
Yeah. Yes.
Okay. Stay on the line. Thank you.
Can everybody hear me now?
Yes.
Yes.
You can.
Okay, I'm sorry for that. So while everybody's phone's unlocked, why don't we go ahead? Is there any questions you have at this point? What challenges are you seeing in your back offices? One of the things that we are seeing as a challenge for many organizations is communication between clinical and authorization staff will be more and more critical as we move forward. The reason is that we're seeing an increase in consumers that results in a greater demand for staff. Schedulers will need to assess the most up-to-date technology in order to get consumers scheduled in the system, and technology will need to be effectively matched to the consumer's insurance plan to be available for authorizations for clinical staff to be able to do that. And so part of the authorization process that we've seen teams do and we recommended is how much of the authorization itself is non-clinical. And can support staff help the clinical staff sort of tee that up, per se. And then the clinical staff member can go in and do their clinical conceptualization of that authorization to really help cut down on the demographic findings and some of those little information, and then be able to tee that up for them to make their lives a little easier. We have to put technology in place that makes matching the plan to clinical staff seamless. We have to educate our staff and try to centralize the functions as much as possible. We are seeing increased caseloads across the country as part of the revenue and cycle piece continues, primarily because we're seeing more and more clients with multiple payers. The challenge we're also seeing is that I may have one insurance this month under the Affordable Care Act, the next month I go on the exchange and I buy a different one. And so that what I have authorization for, if I don't continually check that authorization and verify payer at every visit, we're seeing a lot of claims go denied because the authorization isn't there or the client is not enrolled in the new provider panel. Billing staff, back office and front staff will need to clearly understand new payer requirements for documentation and coding, and we'll see reduced timely filing will require that staff document efficiently. We're seeing in some states they're even moving to, if it's a Medicaid provider per se, that it has to be billed within 90 days. The most I've seen is maybe now 180 days. If we can't bill outside of 180 days, then the provider doesn't get paid. So do you need to increase clinical staff to handle increasing caseloads, and where will they come from? Do you need to hire more support team professionals, billers, coders, scrubbers? And we're seeing that our lessons learned from larger healthcare, especially on the billing and coding side, is that we've not necessarily had a lot of coders within behavioral healthcare. And it's becoming more and more important that we either subcontract that out or share staff to some degree. We're really looking at having billing coders on your team. So that's part of the staffing consideration to look at. And then we have to educate our clinical staff on documentation coding requirements. So both ends of the house need to understand what the other one's doing. That internal customer service becomes more and more important. Effectively implementing systems and processes related to the encounter and documentation will increase efficiency in the charge capture process. So example, same-day access and collaborative documentation will result in a same-day charge capture. So if I can get you in today, verify your insurance, verify your payer, get the authorization, get you in the door, and the clinician documents today, collaboratively in session with the patient or family present, complete that assessment, and I can bill for that today if I had to. The other thing that we're seeing is numerous new plans will be in place for more and more consumers, new billing rules, timely filing codes, and higher costs. So how do you collect and account for the expected increase in copays and deductibles? That's one of the biggest challenges that I've seen in national community behavioral health, is that we've traditionally been uncomfortable asking for money. And so we've had to look at scripting that out for staff, making sure that also our clinical staff understand that clients have to pay the bill. The clients will need to be able to provide some level of funding for their copays and deductibles. What's our front desk and reception staff scripting that out for them? Are we giving clients billing statements for that? What's our checkout procedure process? Other solutions that we see is developing new policies and procedures. What do you do when a client returns to services with an outstanding balance? What happens if they don't make payments today? And develop policies and procedures around that. Implement technology or process that focuses on communication between revenue cycle and clinical staff, and educate all of our staff. Expect a significant increase in pending or denied claims, so plan for the impact on cash flow. Some of that solutions are looking at improved front-end processes, having technology. Consider moving staff that have been previously involved in the billing process to the front end of the revenue cycle to assist. Increasing copayments and deductibles, timely filing, all these things are continually having more and more impact on our providers. So on compliance, the other thing we wanted to do to help with revenue cycle is do a baseline analysis to determine where problems are today. So on your compliance issues on the revenue cycle, what are we having to write off because we didn't have a updated treatment plan? We didn't have a authorization for that service. We have to monitor constantly, including medical necessity reviews, ensure clinical staff are trained on changes to impact service delivery and documentation, and monitor our denial rates. Monitor your denial rates by payer, by provider. Other things we're seeing is challenge with timely access to treatment to support third-party payer referral requirements. We're seeing a lot of new third-party or ACO requiring same day, next day, or within 3 business days for consumers to get in. Other challenges, community awareness and branding to increase third-party payers. Inconsistent revenue cycle management procedures, perhaps inconsistent message to the community. That's where you go for free care. That's where you go for free medicine. And understanding of our target markets in our community. Who's the largest payer? Who's the largest provider in your market? Who's the largest employer? What's the percentage of uninsured, insured, Medicaid, Medicare in your market? How does that compare to your current payer mix? So honing in on that pre-service audit component, admission eligibility, pre-service authorization, verification for service. So the pre-service component consists of contract and enrollment management, patient scheduling, medical necessity, eligibility, registration, and pre-service audit. So do we have a contract? Are we looking at those contracts on a regular basis? Are we looking at our rates, going back in and perhaps negotiating and renegotiating? So we're asking teams to develop internal protocols for all support team members regarding contract and enrollment. Anchor the KPIs, the key performance indicators, performance measures, and protocols into the actual job descriptions. Assume that all consumers have the appropriate authorization, updated treatment plans, and the services scheduled are ordered in the treatment plan prior to services being scheduled. So we want to assure that that's there. If not ordered, assessed, or authorized, or medically necessary, don't schedule. I was working with a team recently, and they had many, close to $500,000 in unauthorized services that they continued to schedule. One of the things they were doing was their actual EHR said, this client has no authorization. Do you want to override? And they kept hitting the yes button for over a year for that particular client, knowing they didn't have authorization. So looking at those levels of eligibility, and so develop protocols for client eligibility and benefits management. Review third-party administration to assist with back-office functions. There's 2 that I'm familiar with. One protocol is called TriZetto. The other is Phreesia. Here's some of their information. TriZetto, I've had personal experience with TriZetto, and it has improved collections on third-party payers. It will allow you to go in and look at, do I have authorization for the service? Is the service, does the client have behavioral health care benefits? It'll allow you to do that. The other is Phreesia, which is basically a large leak pad kind of product. They'll allow you to go in ahead of time or at points of service and look at authorization. It even has a place where the client can actually go in and swipe their credit card or debit card and make a payment for you. What I like about TriZetto, it does allow you 72 hours in advance to go in and load and say, these are the clients that are coming in 72 hours from today. Do we have authorization? Do we know the right payer? Do they have the service? Are we checking the Medicaid system on a regular basis to make sure the client continues to have the appropriate Medicaid payer? So again, looking at developing those protocols and KPIs for client registration into the state or appropriate payer portals. Example, all new consumers will be registered same day of service 100% of the time. Here's some financial intake KPIs. Definition of financial intake packet, annual updates, as status changes, or rates required by program was completed on all individuals requesting service with the center. Financial intake and paperwork will be entered by the support staff to CMHC, CIS, the EHR prior to the date of the clinical intake, monthly audit financials, solution plans, compliance ratings. So again, drilling this down and anchoring it in actual job performance. Confirmation reminder calls. During the confirmation calls, the consumer representative will not only confirm the appointment, but also will confirm the outstanding balance and the copay as needed. So thank you, Tabitha, for coming to XYZ Agency. Just let to confirm that you have an appointment with Dale Thursday at 3 p.m. if that's so convenient for you. Please be reminded that you have a $40 copay and your current balance is $300. Here's a pre-service audit tool. So again, develop that 72-hour protocol for open access to care, develop protocols for same-day review of eligibility and consumer fee determination. And this is just going to be a yes, no. I'm going to go in and look at the demographic information. I'm going to go in and look at the financial information and the point of service. I'm going to go in and look at those things that has the assessment been updated within a year? Is the treatment plan up to date and live? Do I have a payer for today's service? And again, if none of that is happening, it's either a yes or no. And that gives you 72 hours to follow up with either that clinician or with that payer to get the authorization for that service. Here's a sample scripting or policy that can be given to an organization to look at this. Most health insurance policies cover behavioral health and substance abuse services to some extent. If you have health insurance, including Medicare or Medicaid, it's important that you give us this information right away. We will bill your service, your insurance company directly so that they can pay us directly. Should your insurance company pay us for what has already been paid, we will credit your account or give you a refund. Your insurance company has billed our full fee. You are responsible for any deductibles, copays, or balance that's not covered by your insurance company. Any deductibles and copays are not eligible for sliding fee adjustment. If your balance after insurance reaches $300, you'll be required to make a payment to lower the balance below $300 or your next appointment will not be scheduled. So think about how that would impact your organization. Do you have something like this in place now? If this was your first visit, we'll attempt to verify your insurance or copay amount at the time of service. A minimum fee of X is required at the point of service. You are responsible for any amounts of your care not covered by your insurance carrier. So again, making sure that our consumers get this information upfront and regularly. If necessary, an extended payment plan may be arranged. If this approach will assist you in paying your bills, please arrange to meet with our client account staff. Should your financial circumstances change, we reserve the right to renew or revise the extended payment plan. And what we've also seen sometimes, the clinician knows the client got a job with insurance, the front desk doesn't know that yet. If your financial circumstances are such that paying the full fee is impossible, you may be eligible for sliding fee, which will allow payment at less than full fee rate. If this approach seems necessary for you, please contact our client account staff. If you are put on a sliding fee schedule, there is a discount applied to your fee if you pay at the time of service. So again, looking at the business practices. At point of service, we're looking at collection of copays, providing that treatment, post-session scheduling, and post-service audit. So again, here, the clinical documentation, so we can get that bill out the door, make sure our coding and our charge capture are placed, and then really doing a full UMUR corporate compliance review. You'll be expected to pay your fee each time you receive service. Credit cards may be accepted. If, however, you are unable to remain current with your account, a different approach may be necessary. Please discuss such circumstances with our client accounts staff or your clinician. If you do not, and payment is not made, we reserve the right to turn your account over to collection. Different approach, would you agree, than perhaps what we've done before? Clinical documentation must support the services provided for the day. Services provided must be on the treatment plan and the assessment of needs. Documentation must be completed and accurately submitted within 24 hours after the service is rendered. Remember that collaborative documentation is a tool, not a rule. The rule is documentation must be turned in within 24 hours. Collaborative is a way to help our staff get there. Other roles of clinical and financial staff and third-party billing is the completion and submission of all required clinical documentation by direct care staff, that authorization, reauthorization after intake, filing timely and accurate claims will be critical on the back office side, and monitoring level of unreimbursed third-party care. So determine the reason for this. What's our denial code? Being able to run a report by denial codes will help us hone in on what's going on. A charge master, kind of looking at your charge capture, is a listing of every single service or procedure that you provide to your consumers and families. Charge masters are key and they help to make the process of billing move more smoothly. So again, I know what an hour of therapy costs by CPT code, by provider type. So charge masters are more than procedures. Your billing department may not always know much about the charges or how the charging process goes. So they may know a little bit, CPT-4, ICD-9, ICD-10 diagnosis, or revenue codes, but only enough to get the claim paid. For the most part, no one in the billing area knows anything about how to create new charges or where they go on the computer system. And so we've seen that education and technology for them. It's key to really help the operations run smoothly. So here's a sample charge master. Again, what's the sliding fee amount? What's the direct fee? what's the full fee amount. I was working with a team recently, and I said, what's your fee for outpatient counseling? Well, they said the Medicaid rate. I said, well, what if I'm insurance? Well, we just charge them the Medicaid rate, as opposed to what the market may bear or what's usual and customary in that market. So review current coding policies and procedures to ensure compliance. We want to be able to review current MAL rates by CPT code, develop KPIs to re-adjudicate denied claims in 24 hours, and develop our ICD-10 protocol. Proper coding is necessary to ensure appropriate reimbursement to avoid audit liability, especially around your E&M codes. You want to look at correct coding implies selection is the most accurate description of what services were provided and why they were provided. The code selections must be supported by the documentation in the medical record. This also applies to regional rural health centers and SUHCs. When working with commercial payers, you should not select codes based solely on the payer's coverage or payment policies. The primary set of codes described on CPT describes the cognitive and procedural services, evaluation and management, psychiatric services, health and behavioral. They're usually 5-digit codes copywritten by the AMA, and payers' fee schedules attached CPT codes, especially, again, also for RHCs and FQHCs. Per CPT, any procedure or service in any section of CPT can be used by any qualified physician or healthcare professional. E&M codes are reported by psychiatrists. We do a lot of work around E&M coding and auditing around E&M codes. David Swan from our team does a lot of that work goes into organizations, reviews the documentation, and reviews E&M codes provided. One recent organization in one quarter left about $250,000 on the table by not code. They were undercoding what they were doing. Again, looking at your HCPCS codes, which are alphanumeric, code and modifier determines the level of reimbursement. So again, making sure you're talking with your billing staff, you're using the appropriate codes, using J codes for your injectable medications for Medicare and Medicaid, and the Medicare modifier, AJ, for services provided by clinical social work. If you're working in an integrated care setting, psychiatric services codes should be reported by behavioral health professionals. E&M codes should be reported by your physicians, MPs, PAs. Psychiatrists may report services from either category, depending on the service provided. They can put a counseling code as needed. And payers may have different coverage and payment policies, so make sure you're looking at each of those for each of your payers. Making sure that we're coding an integrated setting, that we have the right diagnosis and distinguished medical and mental health diagnoses. Providers select diagnoses that are chiefly responsible for the services provided. Report only codes you treat or that impact treatment. Use codes for signs and symptoms until diagnosis can be determined. Again, briefly looking at your ICD-10 and your DSM-5, insurance companies must follow HIPAA, and ICD is the only HIPAA-compliant code set. DSM is not an official HIPAA code set. ICD is the only official diagnostic code set for billing. So reimbursement for your services will be dependent on your ability to adapt to the official code set. So we're seeing some organizations sort of keep DSM-5 on the front end and then do a conversion on the back end, or actually use both for their clients. Remember that the HIPAA standards require the data elements under ICD-10. The diagnosis is one of the required quality indicators and elements used in our process. The clinical documentation is needed to support the diagnosis in the clinical record. And so as we move from ICD-9 to ICD-10, we're going from 3 to 5 digits to 7. The first digit is alpha or numeric under 9. The first digit is always alpha under 10. Digits are 2 to 5 are numeric. Digits 3 to 7 are alpha or numeric with a decimal after 3 characters. And so we went from 13,000 codes in ICD-9 to 68,000 codes in ICD-10. If you're doing inpatient work, you can see the changes here. If you're doing any crisis or inpatient, again, 87,000 codes on our ICD-10 for mostly inpatient, but a lot lower for behavioral health. So here's an example kind of narrative. It's a challenge that we're seeing as you educate some of your staff around the specificity of documentation to be able to support the code to help support revenue cycle. So if we look at DSM-4, the code for bipolar I disorder, 296.54, under 5, it's the same code. Under ICD-9, it's 296.55. Under ICD-10, it's F31.5. So we're seeing a change. If we're, so we have to update, and I'm sure many of you have already updated your systems as of October 1st to be compliant with ICD-10 and looking at your current client. Under utilization management is another key component after that point of service that we talked about. They develop protocols to review services delivered versus services ordered on the treatment plan. And so we have to make sure that any service that we provide is actually ordered on the plan. So if you're providing case management, is it on the plan? Otherwise, it's going to be denied. If you're providing case management to a Medicare patient that doesn't have any form of other payer, will not give you pay. To develop this audit functions to review medical necessity and compliance, report back to staff and to leadership and managers and direct care staff on how to improve their processes. Another key component is centralized scheduling. This is needed to ensure referral is based to clinician on the appropriate insurance panel. Bless you. Do we have the right clinician with the right payer, with the right client at the point of service? So here we have to rethink the front desk functions. The collection of copays prior to service, confirmation of insurance via copy of insurance cards prior to service being rendered. So I'm going to check that at the point. So here's the sample copay reimbursement for services, KPI. Collection for all billable service copays provided by the center staff will be executed at each customer visit. The customer service representative staff will accurately collect, bill for services at the point of service. And you're going to review that, and you want a 98% compliance rating on that at the front desk. And what happens if I'm not compliant? As we move to point of service, that's the billing, denial management, accounts receivable, cash posting, and consumer follow-up. Looking at your denial management is key on this one. Again, as we said earlier, making sure that we're looking at it by denial code. And who are our frequent flyers on that? Do I have a specific clinician? Do I have a specific payer? And accelerating cash is what are your current days of sales outstanding? What's your AR look like? After services are delivered, behavioral healthcare organizations' revenue cycle needs to assess and maximize revenue capture and streamline the billing and collection process. So making sure that we're doing as much electronic claim processing as we can, direct entry of Medicare and Medicaid claims, automatic secondary or waterfall billing to multiple payers, remittance posting, and contract and denial management are all part of that cash collection component. So here's a non-clinical indicator. Client statements will be accurate and issued to each individual via mail each month. Client statements will be reviewed for accuracy and mailed out no later than the 20th day of each month. Client statements, so then we're going to have a client statement spreadsheet, and we want a 98% accuracy rate on that distribution. Anything less than 98% is inaccurate. And so when we look at access management, claims management, posted payments, and so we're seeing that access to care and workflow processes eliminate redundant collections. Here's our work that we did in Georgia, where the CSCs had to obtain authorization for services, determine and validate coverage for payment, assess payment risk, and schedule resources prior to consumers coming in. Here's one way for check-in. And so Mr. Flores, have there been any changes in your insurance since last time we've seen you? Yes, there is. So you have to fill this out, give the front desk, and then they're able to enter that information in real time as the client has that up-to-date information. Also assessing our third-party payer assessment sheet. I realize that some payers aren't worth going after, and so this sheet specifically has per payer on one side, credentialing requirements, what is required for credentialing, what licensure is required, is there a pre-certification required, custom clinical forms, is the panel open, yes or no, what's the rate structure, status notes, do you recommend pursuing? If they're only going to pay you $35, that may not be worth pursuing, especially if the rest of that has to come from the client. And so this allows you to evaluate third-party payers. Other non-clinical performance indicators, accurate billing statements will be generated and issued to consumers no longer than 20 business days after the month end. Based on the number of consumers billed, substantiated consumers' complaints will not exceed 2%. So again, anchoring those into reporting and measurement and KPIs. So what about the payers? Do we know our payer expectations? Do we have relationships, or our billing staff have specific relationships? What payers are currently in your market? What is your percentage of Medicaid in your market? What is the percentage of Medicare? What is the percentage of uninsured? What is the percentage of insured? What are the top insurance panels in your market? So again, asking yourself to look at that. One of the things that we do with teams across the country is we have developed a back office readiness assessment to really look at where the teams are. This back office administrative tool, the BART, provides an opportunity for the management team and CDHOs to review several important service process supports and administrative function areas that have been proven essential to support appropriate billing and collection in an enhanced managed care funding environment. And so MTM Services team has identified core assessment focus areas based on the typical identified challenges within an organization. So again, we talked about being accessible, being efficient, having electronic health records, focus on episode of care needs, produce outcomes, engage clients, and reduce needs for emergent and high-cost services. We have to focus on the credentialing of staff on provider panels, internal referrals to appropriately credentialed staff, obtaining pre-certifications, authorizations, and reauthorizations as needed for continued service, support enrollment needs of our clients, clinical focus to meet the managed care best practices that treat to target, collection of copays, and accurate and timely claims submission. The BART is a self-assessment tool that will require your management team to schedule joint time to meet to work out these areas. What we see most teams taking about 6 to 8 hours to complete the basic service delivery process measurement tools. So here's the area that BART focuses on. There's several questions in each of those. Again, you can see similarities here: pre-service and access to care, point of service, customer service, both internal and external, client attendance principles and practices, no-show management, those types of things, cost-based key performance indicators, KPIs anchored in job descriptions. What are your UR credentialing and authorization processes? Looking at your diversified payer mix, your third-party and revenue cycle management billing practices and procedures, your post-service, post-discharge accounts receivable management, billing, cash posting, follow-up, and really, how are we ready for change? Are we looking for change? How does our organization embrace change in what we do? At this time, I'd like to open it up for possible discussion, or if you have any questions of me.
So, do you have? Will you provide us with any of those documents? There's a ton of documents in this PowerPoint presentation. Could you provide us with sample versions of those documents?
I can, yes.
Okay, thank you.
Hey there, this is Tabitha. I was wondering if you could just give a little bit more detail about next steps in your reaching out to all of the providers on this call for individual interviews and assessment.
Sure. Thank you, Tabitha. One of the things we're thinking of doing is you have an opportunity to be part of the assessment phase, completing the BART. And so part of that will be you and your management team completing the assessment tool. And then I would be on the call. We schedule a 2-hour meeting with you to review your answers or responses. You would send that back to me. You would send it to me. I would meet with you over the phone, and then I would write a findings and recommendations report to give to you. And then we would have a 1-hour meeting to review the findings and recommendations based on your reporting. And so it's kind of a condensed focus area, and then looking at kind of where you would go from there. What are your areas of strength, and what are your areas of opportunity for improvement based on the score of the BART? Is that what you needed, Tabitha?
That sounds perfect. Thanks.
Any other questions, team? Well, hearing none, I'd like to thank you for your time today. Feel free to email me if you do have any other questions coming up, and I look forward to our future work together. Thank you all.